There is a small act almost every person over 60 performs without a second thought. A hand reaches into a cabinet, closes around a familiar bottle, and swallows something that has caused no trouble before. No hesitation, no question, just habit built over decades. But what if that habit, repeated week after week, is one of the most overlooked contributors to heart strain in people over 60? What if the real risk isn't found in the pharmacy aisle everyone fears, but in the bottles sitting quietly in room cabinets across the country, taken so often they've become invisible? This isn't a story meant to frighten you away from medicine. Medicine, used correctly, saves lives and preserves independence. This is a story about 6 categories of substances, some prescribed, some bought without a second glance, that behave differently inside a body that has crossed the threshold of 60. Not because those substances changed, because the body did. And understanding exactly how that shift happens is what separates a person who reacts to a health crisis from one who prevents it entirely. Before we walk through those 6 categories, there's a foundational shift you need to understand first, because without it, nothing that follows will make full sense. Somewhere around midlife, the kidneys begin filtering blood more slowly. The liver, once efficient at breaking down compounds, processes them at a reduced rate. The ratio of fat to muscle in the body gradually increases, and that matters more than people realize, because fat-soluble substances behave differently once there's more tissue for them to settle into. Meanwhile, the cardiovascular system loses some of its buffer. Arteries that were once elastic and responsive become slightly stiffer. The heart's internal wiring, the electrical system that keeps its rhythm steady, becomes a little less forgiving of stress. And the baroreflex, the built-in mechanism that prevents blood pressure from spiking suddenly when you stand up, exercise, or feel a jolt of stress, slows down. What does that mean in practical terms? A dose that produced zero noticeable effect at 45 can produce a measurable, sometimes dangerous, response at 68. This is not decline in the way people fear that word. It's recalibration. And recalibration means the rules for what's safe quietly shift, even when nothing on the label has changed. Picture a Sunday morning. Coffee brewing, a slight ache behind the sinuses, the first sign of a cold settling in. A hand opens the cabinet, and there it is, the small orange pill that has worked every winter for as long as anyone can remember. This is where our first category begins. Nasal decongestants. The nose is completely blocked, breathing feels like a struggle, and relief arrives within minutes. It works because these medications narrow the blood vessels inside the nasal passages, reducing swelling and reopening the airway. But blood vessels are not isolated systems. The same signal that tells a nasal vessel to tighten can travel to arteries throughout the entire circulatory system, including the coronary arteries feeding the heart itself. In a younger, more elastic cardiovascular system, this effect is usually mild and short-lived. In someone over 60, particularly someone who already has elevated blood pressure or the beginnings of arterial stiffness, that same constriction can trigger a real spike in blood pressure and heart rate, adding strain to a system with less reserve to absorb it. There's an added twist worth knowing. Some oral decongestants have faced growing clinical scrutiny over whether they're even effective at the doses sold over the counter, which raises an uncomfortable possibility. Some people may be accepting real cardiovascular risk for a product that isn't providing meaningful relief in return. Steam, saline rinses, humidification, and antihistamines when allergies are the underlying trigger offer slower but gentler alternatives. They won't feel as instantly satisfying, but for a heart with reduced reserve, instant isn't always the safest goal. Now picture different scene. A garden, a Saturday afternoon, a knee that complains after an hour of kneeling in the dirt. The bottle reached for this time is even more familiar than the last. Our second category lives in nearly every household, used so casually that most people never think of it as a cardiovascular decision at all. Anti-inflammatory pain relievers. Used occasionally, the risk profile looks very different than what follows. The real concern surfaces with repeated, sustained use, taken daily or several times a week without medical oversight. These medications block certain chemical messengers in the body, and while that blocking reduces inflammation, those same messengers also help regulate blood pressure, protect kidney function, and influence how easily blood clots. Suppress them chronically, and the downstream effects can include fluid retention, tightened blood vessels, elevated blood pressure, and a subtle shift toward a more clot-prone state. Researchers have also documented direct effects on heart muscle tissue in people who already carry cardiac risk factors. One substance deserves to be separated from this conversation entirely. Low-dose aspirin, prescribed deliberately by a cardiologist with a documented history of cardiovascular events, plays a completely different role, used precisely for its blood-thinning properties under medical supervision as a calculated risk reduction strategy. That is nothing like reaching for a standard anti-inflammatory every time a joint aches. And here's something rarely mentioned in these conversations: much of the joint pain that worsens with age isn't purely mechanical wear. Pain leads to less movement. Less movement leads to weaker supporting muscles. Weaker muscles place more load on the joint, which increases pain again. The medication quiets the symptom, but the cycle underneath keeps turning. Gentle, consistent, medically appropriate movement has repeatedly shown the ability to interrupt that cycle in ways a pill never can, without adding cardiovascular cost. The third category is the one that deserves the most patience to understand, because its danger doesn't announce itself. It hides in plain sight, refilled automatically for years. Acid-reducing medications, commonly prescribed for reflux and ulcers, are genuinely valuable when used for their intended, time-limited purpose. The trouble begins when a short-term prescription quietly becomes a permanent one, refilled year after year long after the original reason has faded from memory. Two things happen during that stretch of time. First, suppressing stomach acid for years alters the internal environment of the gut, a system that plays a quiet but important role in defending against pathogens and maintaining microbial balance. Second, and this one is well established, vitamin B12 absorption depends on stomach acid, specifically a protein called intrinsic factor that requires an acidic environment to function. When that acid is chronically suppressed, absorption declines gradually, almost silently, and B12 deficiency doesn't arrive with a dramatic symptom. It shows up as fatigue that doesn't make sense, mental fog, weakness, sometimes tingling in the hands and feet, sometimes something that looks disturbingly like early cognitive decline, until lab work reveals a level that quietly drops for years of unreviewed medication. If a prescription like this has gone more than a year without a check-in, two questions are worth bringing to a doctor. Do I still need this, and has my B12 been tested recently? We're now at the midpoint of this list, and it's worth pausing to reset the frame, because the goal here was never to build distrust toward medicine. Medicine, applied thoughtfully, extends life and preserves independence in remarkable ways. The pattern worth noticing is different. These medications are often started for a clear, legitimate reason, and then time moves forward while the original question, "Is this still necessary?" never gets asked again. Asking it isn't difficult behavior. It's engaged behavior. And that engagement is what catches a problem while there's still time to change course. Now imagine a different kind of emergency: a sudden allergic reaction, a chest tightening with an asthma flare, an autoimmune condition igniting without warning. Here, the fourth category earns its reputation. Corticosteroids can be exactly what a situation requires, and that shouldn't be minimized. What deserves more attention is the physiological cost that rides alongside the benefit. These medications promote sodium and water retention, which increases blood volume, and more blood volume means more pressure against arterial walls that, past 60, have already lost some elasticity. That combination can produce a sustained rise in blood pressure. It can accelerate fluid buildup in the legs, shift how the body handles blood sugar in ways that can temporarily mimic or worsen diabetes, and alter both cholesterol levels and clotting tendency. The danger rarely comes from short, well-monitored use. It comes from the gaps: an injection given without a scheduled follow-up, an oral course quietly extended, a condition long resolved while the prescription keeps renewing out of habit. Anyone using corticosteroids in any form for more than a few weeks deserves regular blood pressure and blood sugar monitoring as a baseline, not an afterthought. The fifth category has changed shape over the last 2 decades, and fairness requires acknowledging that shift honestly. Testosterone therapy surged in popularity as men noticed declining energy and shrinking muscle mass, marketed as restoration of something lost to time. Earlier research raised real concern that testosterone in older men might increase heart attack and stroke risk. More recent, better-designed studies complicate that picture. When there's a documented, lab-confirmed deficiency and treatment is carefully dosed and monitored, the cardiovascular risk appears less severe than once believed. The real danger lives in the gap between those two conditions, confirmed deficiency and careful management, because a large share of testosterone use today happens outside that gap entirely, obtained through symptom checklists alone, without adequate baseline labs or ongoing monitoring of hematocrit, the concentration of red blood cells in the bloodstream. Testosterone can push that concentration higher, and thicker blood clots more readily, a real concern in arteries that already carry some narrowing. The question worth asking isn't whether testosterone causes heart attacks in general. It's whether a full cardiovascular evaluation was done, whether hematocrit is being tracked, and whether this treatment is addressing a real deficiency or simply chasing a feeling of youth without that foundation underneath it. Which brings us to the final scene, and perhaps the most overlooked of all. A late afternoon slump, a craving for focus, a supplement bottle promising energy without the crash. Prescribed stimulant medications, when used under careful medical supervision for a properly diagnosed condition, offer genuine benefit. But starting them later in life without a thorough cardiac evaluation deserves far more scrutiny than it typically receives, since stimulants raise heart rate, constrict blood vessels, and elevate blood pressure. None of it trivial for a system already running with reduced reserve. What concerns clinicians even more, because of its scale and near-total lack of regulation, is the supplement industry built around energy and rapid weight loss. The word supplement carries a soothing reputation it doesn't always earn. Some of these products contain stimulant compounds that activate the exact same pathways as prescription stimulants. Others contain diuretics that produce a dramatic drop on the scale that has nothing to do with fat loss, only water, and losing water rapidly in a body whose kidneys already work at a slower pace sets off a cascade of electrolyte shifts and concentrated blood. The weight returns within days, and the cycle repeats, each round placing a little more demand on a heart that never needed the extra load. So what do you actually do with all of this? Not anxiety. Something far more useful, awareness paired with action. Never stop a prescribed medication abruptly because of something read or watched online, this video included. Abrupt discontinuation, particularly of cardiovascular medications or corticosteroids, can be more dangerous than the concern that prompted the worry. Any change belongs in a conversation with a physician, with a plan, and with monitoring. Build a complete list of everything you take: prescriptions, over-the-counter products, supplements, vitamins, and bring it to your next appointment with a direct request. Walk through this with me. Is each of these still necessary? Is there a safer alternative for someone at this stage of life? When was this last reviewed? None of these 6 categories are rare. They sit in ordinary cabinets, in ordinary homes, taken by ordinary people who never thought to question them because the habit never felt dangerous. That's precisely the point. The body reaching for that bottle today is not the same body that first reached for it decades ago. And it deserves a conversation, not out of fear, but out of respect for how much has quietly changed underneath the surface. Somewhere tonight, someone will open a medicine cabinet without thinking twice. Maybe, after today, that pause will last just 1 second longer, long enough to ask a single question. Is this still the right choice for the person I am now?